Assalamu alaikum. Thank you so much, the Minas-Sino committee, for inviting me for a talk. I have mentioned here the Well Cornell Medicine at Khyber Medical University because most of all the work I'm going to present was done in Well Cornell Medicine, Qatar, and New York. So, yeah. I'm talking about ophthalmic imaging marker in ischemic stroke. So we all know that stroke is the leading cause of acquired disability and second most cause of death in the world. Unfortunately, in the MENA region, MENA region basically, including Pakistan, it occurs at very early age, around about like 55 years. And it is more than 60% of the patients are below 50 years of age. That's lead to premature disability. The risk factors are the same: the diabetes, hypertension, smoking, and dyslipidemia and metabolic syndrome. So currently the technique that we have are the CT scan and MRI to detect the damage that has been occurred due to stroke. The imaging markers are the in MR. There are the silent infarcts, microbleeds, white matter in hyperintensities. So our concern has been that these CT scan and magnetic resonance imaging cannot be performed to detect the early, even pre-stroke neuronal damage. So we were interested to work on something that we can detect pre-stroke neuronal damage. For that purpose, most of the studies that has been done in relationship with the eye and the stroke, they have been focused on the retinal vessels blockages or retinal neurofiber defects and optic nerve. But we are going to work on cornea. So the cornea is at the anterior part of the eye. It is a fascinating part, and we are going to look at the corneal nerves. These are the nerves that we have pioneered this technique to image these nerves in different neuropathies, and we are working for my team has been working for last 2 decades. Before it was started in diabetic neuropathies, then after 2015 we started in neurodegenerative conditions. So the human cornea consists of 5 layers: is epithelium, Bowman's layer, stroma, Descemet's membrane, and endothelium. So the nerves are in the subbasal layers at the Bowman's layer, so we can image them with through using the in vivo corneal confocal microscopy. I'm going to tell them about later. These are architecture of the nerves. In the superior and nasal side, we make them 600 times bigger. So they enter from uniformly from corneal limbal, scleral limbus. They are thicker in the beginning. When they move forward, so they become thinner and give rise to mid-stromal plexus. So there is, for last 3 days, I'm only listening about the scary stuff, all the intervention and needles. But over here, the good thing about this technique is that it's non-invasive. It easily can be done, and you can capture a lot of nerves within 10-15 minutes. That gives you good amount of data to decide on the neuronal damage. So this is the techniques where I'm going to examine patients. You can see the cornea over there, and you can, in the next image, is the corneal nerves. The white lines are the nerves. Along with them, there are some dendritic cells as well, immune cells. And the next image is about how we analyze these corneal nerve parameters. So there are three parameters that we are going to measure in that. One is the length of the nerve. That's, for example, we see with the red light, and branches that come out from the main fibers, the red lines. So those are the branches, and all the nerves in a single image are called corneal nerve fiber density. So we got three parameters: corneal nerve fiber length, corneal nerve fiber density, and corneal nerve fiber branches. So this looks like in architecture of corneal nerves. They are coming from the periphery of the corneal-scleral limbus. Okay, so they are going to one point. They are going to exit at nasal inferior side. They make or there a hole. And usually, like if the patient is ready, so in just 3 minutes you can have like 100, 200 images that are enough to make a decision on that. So when you're going to use corneal confocal microscopy, so we are going to move forward. So we are going to see these layers. The first is epithelium. So the next is like nerves, and then stroma, and then endothelium. So yeah, so the technique was, as I mentioned, because it was used first for the diabetic neuropathies, and in the first image we can see with neuropathy there are it's little bit when you're going to detect the mosaics, the whole corneal image, you're going to cover the whole cornea and the whole image is, so you need to make them a mosaic. So it's a little bit, there are some compression in it. But the first one is with the diabetic neuropathy, and the other one is without neuropathy. Sometimes you can see some of the patches where the nerves are lost over there. So what was the objective of the doing corneal confocal microscopy in the stroke? So the main thing was that we wanted to see quantify the corneal nerves and the pre-stroke neuronal damage, and to compare that the pre-stroke damage with the outcomes, and to establish the relationship between corneal nerves and the risk factors for the stroke. So I was planning to move from Australia to Eastern US to Cornell, and then Professor Ashfaq, I never knew about him before this. He was moving to Doha, Qatar, and there was a guy, Professor Yas Malik. He has done extensive work on corneal confocal microscopy along with our team in Brisbane, in Australia. So these two giants were coming to Qatar to work, and I was thinking to stay for a very little while over there in Cornell, but they forced me to stay longer, and we are going to start stroke program. They have already started in this, need to start stroke corneal confocal microscopy. So this is the place they need brought in. So you can see that's how we started. You can see on the right side Professor Maher over there. So it was a very busy clinic and it was very sensitive stuff, but when we first going to start, so it looked like that. The patient is over there with the OCT basically. I will talk about that as well. So I think he's confused where I am because he has got large vessel occlusion at that very time. And yeah, but my profs, Professor Malek and Professor Schwab, they were driving the Ferraris. So they hand over everything to me and Professor Maher to work out. Okay, so the first study that we did it We look at first ischemic stroke patients. There were over 146 stroke patients and 18 controls. So, the clinical parameters were higher in the stroke patients as compared to the control one. So, what we found, irrespective of their glucose levels, there was neuronal damage in the sense of corneal nerve damage. It was over there. So, we published that in the stroke in 2017. You can see the first image is about the healthy control one. The second one is the stroke patients with normal glycemia. And the C is about the impaired glucose patients. And the last one, the diabetic one, have more severe neuronal damage, is the D1. So the result showed it's a similar results, but in the graph forms. Okay, we can see the green bar has the highest neuronal reserves as compared to the other three one. And it's a corneal fiber density. All the parameters were lower in the stroke patients, irrespective of the glycemia, the C and corneal branches, as well as the length of the nerves. We look at the association. We found the association with the triglycerides, HbA1c, and BMI, except the branches. The BMI were not related with the branches, and somehow the nerve fiber density was going to be associated. Okay, so next thing we were going to do was, is there any relationship with the inflammatory markers? So we did a study and look at the corneal nerves and with the inflammatory markers, and look at TIA patient as well as the stroke. So we want to look at whether there is a difference between TIA and the stroke patients, neuronal damage. So there was difference, there were more neuronal damage in the TIA patient as compared to healthy control. There were in stroke, it's already established that there was the damage. In control, we look at the corneal fiber density as compared to without white matter hyperintensities. This is a figure. I'm going to come to the graphs, the right lower one. So we can see over there that CNFD was lower in the patients with white matter hyperintensities compared to the non. Next thing that we were going to do, whether the patients with the second stroke, they have got one stroke and after some time they got another stroke, where there was some difference between their neuronal results. So we found that the patients with the second stroke were having more corneal damage than the patients with the first stroke. We can see in the graph is the CNFL. If you look at corneal nerve fiber density and corneal nerve fiber length, so they were the corneal nerve fiber density was lower much lower in second stroke as compared to the first stroke. And the other parameters were comparable. The other most important bit when you're going to develop the imaging markers or the biomarkers, so you need to look at like whether with the improvement, whether the technique is going to detect the changes as well. So we look at the vascular factors, did a longitudinal study and look at the patients at first at the baseline and after a year. And we are going to look whether these vascular factors are going to improve the neuronal results. So we did this in 56 control and HE1, TIA and stroke patients. So if you look at the bottom, along with the improvement of the vascular factors, we got the improvement in the neuronal results as well. So it's in a preprint. It's going to come up very soon. So the next thing that Professor Schwab was very interested, it is his main niche, pile collaterals. So he wanted to whether the patients with those who get poor collaterals have more neuronal damage than the whether as compared to the good collaterals. So we look at the patients, the good collaterals and with the bad collaterals. So in the figure A, we can see the good healthy control, the B with the moderate and good collaterals, and the C with the poor collaterals. So we can see the difference that it's more neuronal damage in the patient with the poor pile collaterals. Here we can see the damage, neuronal damage in the different collateral status. So we were interested whether these nerve parameters are able to differentiate between the poor and good collateral patients. So what we found that if we looking at the nerve fiber length and the branches, so it's going to help us 72% the length, and the branches are going to help us 71%. So we can differentiate with them. This is the retinal part that most of the people has done. But there's a first study that showed that retinal matrix are correlated with the pile collateral status. But that was done by James Faber in mice. So we want to translate that findings. So we got like 21 control patients with the 35 ischemic stroke with a large vessel occlusion, and I want to appreciate Professor Mahi and helped me a lot in that. So we got the OCT of the patients, where there we can see in the right side the retinal vessels, and we got the large vessel occlusion patients, and we classified the retinal matrix in different dimensions. So the multifractal dimension, these parameters are very important. It has been established in the literature that retinal fractures are associated with the substrokes and different types of strokes, but it was not established in the large vessel occlusion pile collateral patients. So this we found these findings, so we published them, and we found that the fractal jets give information about the retinal vessels are higher in poor collaterals as compared to good collaterals. We can see the D0, D1. Okay, and this, when we did machine learning to separate the retinal matrix of poor collateral and good collateral of the patients, so it told us about like 75% patients can be differentiated between poor and good collaterals by using retinal matrix. Yeah, so yeah, we are here. Thank you. So the conclusion is that we found that there is neuronal pathology in patients with acute ischemic stroke, and These represent the cumulative risk factors who are going to do those damage. And we are proposing like corneal nerve fiber predictor index, so that like we can triage the patients with the TIA, stroke, and in the recurrent stroke. We are going to analyze the data about the corneal nerves damage and the outcomes, and we have the finding that it's related with the 90 days MRI score. So if somebody has poor, low corneal nerve reserves, so they have more disabilities. We are going to do a large-scale study that's about the retinal matrix in the pial collaterals to establish this technique to separate pial good and bad collaterals. Thank you. Do you have any questions?